Well, welcome to the final plenary session of the conference, and welcome to those of you who have made such an effort to come and hear about non-communicable diseases. My name is Dr. Judith Mackay with the World Lung Foundation, and my co-chair is Monica Arora from India, and we have a team of distinguished panelists, and we'll introduce them one by one as they speak. The format will be that Edouard will speak first but has to leave, so any questions to his first presentation will be immediately after it. And then the rest of the speakers will speak, and then at the end we'll have all the questions. We welcome questions from the floor if we have time to do that. So the session will broadly aim to emphasize the need to promote tobacco control to achieve the NCD targets by 2025. So speakers will discuss the acceleration of tobacco control policy and health system interventions to achieve this NCD reduction across the globe, broaden tobacco control, integrate it with sustainable development, and move towards a tobacco endgame. That will highlight the role of health systems and civil society in further strengthening this and aligning it with universal healthcare coverage. And finally, we'll hear a discussion of the economic costs of inaction in tobacco control that is projected to have a catastrophic impact on government health spending and budgets. So without further ado, could I introduce Monica to introduce our first speaker?
I'm very happy to introduce Dr. Edward Despaigne, who's joined WHO Tobacco-Free Initiative in December 2008 as Coordinator of Comprehensive Information Center Systems for Tobacco Control, called as CIC. He's currently also responsible for managing the WHO research agenda for tobacco control. Dr. Despaigne will be speaking on monitoring progress towards the 2025 global NCD tobacco target.
Thank you, Monica, and thank you, everybody. Good morning, everybody. Hope you've had a good week. I've certainly had a very interesting week. I've only got 7 minutes to talk, so I better rush through this. I'm sure by now you've all heard and you all know about the NCD Global Voluntary Target for Tobacco, which is to achieve by 2025 a 30% relative reduction in tobacco use among persons aged 15 years and over, using 2010 as the baseline. Tobacco use, I'll remind everybody, is about tobacco smoking plus smokeless. We have a fair amount of data on tobacco smoking around the world. We are getting better at having multiple data points on smokeless, but we are not quite there yet. So we've done some trends analysis in WHO, but they've addressed only tobacco smoking at this stage, and we hope at the end of this year to have a good look at smokeless and see whether we can also do some trend analysis for this. If we have the 30% relative reduction, it might just be useful to explain to you quickly how we arrived at that 30% or how member states arrived at that 30%. And I'm only showing you here 5 countries, but there were 8 countries altogether in the world in around 2010, 2011 that had implemented at least 3 of the WHO FCTC demand reduction measures or the power measures of Empower at the highest level. So we looked at those 8 countries, and I'm only showing you here 5 because 8 you wouldn't be able to read them on the screen. And I start at the bottom. Uruguay from 2000 to 2005 had been stuck at 35% prevalence level. Nothing was moving. And then in 2005, 2006, they started putting in some very, very strong measures leading to having at least 3 of the measures at the highest level, and their rate plummeted very rapidly between 2005 and 2011 at the rate of minus 1.2% per year. Turkey itself was dropping slowly between 2003 and 2008 at a minus 0.5%, but then in 2008 started putting in some very strong measures, and there was this rapid decline in Turkey at minus 1% per year for the 3 years. So it does what we expect the Empower to do. If you implement them, you get good action on them. Thailand, on the other hand, is an interesting country, a very proud history of tobacco control. Between 1991 and 2007 had been going down at minus 0.7% per annum, but between 2007 and 2009, when we did the GATT survey in Thailand, we saw that they actually had gone the other way, and there was a question there which the Thai authorities dealt with, which was to do with roll your own sort of local tobacco, that people were switching from the highly taxed products to those other products. But there was a fair amount of work sensitizing people about the dangers of these products, and between 2009 and 2011, at least it did not keep going on that trend up. You know, it stayed fixed. So hopefully the next survey will show that, you know, that rate, that tendency is now going back down. I'll jump up to Australia quickly. We all know about Australia. At that point in time when we did the targets, it was up to 2010, and we saw that Australia had put in some very strong measures, and they were coming down at 0.7% per year between 1991 and 2004, so every year 0.7% decline. And between 2004 and 2010, that had slowed down to minus 0.5. And in the last survey, which was done after the target was set, the NCD global target was set, we know that they've had the plain packaging, and they've had the strong measures on taxation, and we can see that they doubled up the rate at which they were declining. So there is a lot of good evidence that the power measures work. Iran is an interesting case. Also, 3 of the top measures in the Empower measures, they haven't moved from 0.5% before or after, but Iran is a country where, in their 3 highest measures, that does not include taxation. So that also, again, tells us that taxation is something which is really important for us. So we wanted to monitor changes in trends to help countries set targets, as well as to monitor where they're going. Very quickly, we used a Bayesian negative binomial regression. We use as much information as possible that we could have from a country, and also use information from countries in the vicinity of that country if we did not have full information. And we used any nationally representative surveys done between 1990 and mid-2014. And the outputs from the modeling exercise, we have the 4 tobacco smoking indicators shown up there for trends between 2000 and 2025, as well as age-specific rates for 2000, 2010, and 2025. This is what it looks like in the publication that we have, but I've just taken the men and women in there and opened that a bit, and hopefully you can see a bit better on this side. So the output that we have looks like year 2000 to 2025, the point estimate of what we expect. So in 2010 for this particular country, and I can't even remember which country that was, in 2010 they were they were estimated to be at 22.1%, and they would reach, on that current trend that they would reach 15.1. The voluntary target, which is on the last row, is what is the 30% of the 2010 value, which is 15.5. So in this particular case, that country is expected to reach its target by 2025. And I'll give you some examples of some countries. So here is Australia. We know it's been doing very well on tobacco control. The diamond-shaped black points on that graph are the country provided, the surveys that the country was doing. The line in the middle is the fitted line of this regression, and it actually fits very nicely. And it says that between 2020 and 2025, Australia will meet the NCD target, and quite comfortably. And therein lies a point that I want to make. I think those countries that are going to meet the target should be much more ambitious rather than the 30%, should consider setting an even higher target, because it looks as if they're going to reach, and therefore they should be setting further targets themselves. And indeed, Australia is one of those countries. If you look at the NCD target, when it was set, they were supposed to reach about 13% in 2025 according to the WHO NCD target, but Australia itself has a target of 10% to be reached by 2018. So they are much, much more ambitious than the NCD target, and I think any country that is going to meet the NCD target should think about setting an even more aspirational target. And these are for Japan, what was going to happen by age. You can see that there's going to be a reduction. This is Italy, which is on a downward trend, but will not meet the target. So this is a country that needs to do a lot more. You have other countries that are flat and are not going anywhere. And then more dangerously, we have countries where the tobacco industry is very active and where their trend is going upwards. So those countries need to do much better. So in the main of the work that we've done, of the 178 countries for whom data is available, we estimate that about 125 countries are trending downwards, but only 37 of them are on a slope that will actually meet the target. So as I said before, those 37, we would really want them to think more than the 30% and try to do much higher than that. And as it is right now, instead of a 30% relative decline, the projections that we've done indicates that we will actually achieve only about 18% rather than 30%. So projections are not predictions. This is not predicting where we will be. This is just saying, if we keep doing what we've been doing, that's where we will end up. So the projection itself should have an element of self-destruction in it, which should encourage people to do more, and that's where we should go. So this is a call for action to attain the 30% target for countries that are not quite there, and for those that will meet, to exceed, to set targets that will exceed. I think it must be just about 7 minutes. This is the team that help us do this. These results are available on those two websites within WHO. And I also take the time here to tell you that we've just released a WHO tobacco control global data bank, which we're trying to put everything we can find on tobacco in this WHO data bank. So it will be a really useful tool. Go and have a look at this. Thank you very much. I hope that was 7 minutes.
Thank you very much, Dr. Despaigne. Since we will have Edward leave after this presentation, if there are questions in the audience, we can take that. Otherwise, we can ask the first question till the time we have people line up on the microphone. Our question to you is, as you have shown that the targets and the adoption of 30% may not help us reach the 25 by 25 goal, then to reach this 50% target, how do developing countries, particularly low and middle income countries, how do they adopt the reduction of tobacco from 30% to 50%? What additional they need to do?
Thank you. The 50% that you referred to is an additional study that was done after the target was set up by some colleagues who looked at the 25 by 25 mortality target and came to the conclusion that if we are going to reach that 25% reduction in mortality, it is not 30% in tobacco that we need. We actually need even more than that. We need 50%. What we've just shown here, there is 125 countries on the downward trend. Only 37 will meet that target, and I am arguing that those 37 should be setting it at least 60% or 50% to actually get there. For those who are not going to reach or to reach that target of 30%, I think we have the empower. We have the proven measures, and I think countries need to be implementing and not to be shy about implementing and to get in there, very actively and vigorously. WHO and all the partners, TFK and the union and so on are all here ready to assist countries. So I think we should be looking at those targets. Be very serious about the timelines that we have to do these and to develop a real plan of action about what do we need to do in the next 6 months and 6 months after that, rather than thinking, what are we going to do in 2025? We really need to know what are we going to be doing in the next few months.
An additional question from us is basically to do with the voluntary assessed contributions to the FCTC. And these are contributions that countries have agreed to. It's not aspirational that we hope countries will contribute. These are contributions that have been agreed to fund the FCTC process. And there are millions behind in terms of governments coming up to the mark and fulfilling that obligation. And I certainly don't want to name and shame countries here, but to point out these are not just the low-income countries. There's some very wealthy countries in that group as well. I mean, what can we do to actually fuel and to fund our FCTC process, which is going to be so essential for taking the forward?
Thank you very much. Again, an important and vexed question that we have to answer and we have to address. It's difficult because if member states do not pay what they have promised to pay, it becomes very difficult, as you say, to implement the measures. I think in WHO we are constantly discussing and thinking about this, and I am hopeful that as people have seen in the last in the last few months, there is a reinvigorated collaboration between WHO and the Convention Secretariat, which I think is a very healthy one at the moment. And yesterday, actually, we were discussing how our regional advisors for tobacco in WHO would be working with country officers to try and convince the governments to pay the dues that they've agreed to pay. But it's an urgent task, and anybody who is here who is lagging behind, I would urge them to do the utmost to pay this, because this is something that if we don't do, we will fail, and ultimately the tobacco industry will win.
So it's not widely known, and not widely known enough. And perhaps it's a topic we should revisit at the next World Conference,
Certainly.
Just to see how adequate the funding is to do the job that we all want the FCTC to do. So thank you.
Thank you.
Thank you very much indeed. And I know Edward now has to leave for another meeting.
Okay,
So
thank you very much.
thank you very much for your contribution. I'd now like to introduce Professor Srinath Reddy, who's the President of the Public Health Foundation of India, and he's going to talk tobacco in NCDs in the post-2015 development era. Srinath.
Thank you, Chairs, and good morning, ladies and gentlemen. Today is a day when several regional groups in India are celebrating the new year. So let me start by wishing you all very well on this auspicious day. But it is not one day or any single day in 2015 that we wish the world well. If we wish the world to be healthy, happy, and prosperous over the next 15 years, or even well beyond into the 21st century, then we ought to be really looking at what that entails in terms of the Sustainable Development Goals and where tobacco control and NCD prevention and control fit into that agenda. When we look at the global health priorities for the next 15 years, we are building on the legacy of the MDGs by accelerating progress on maternal and child health, infectious diseases, and undernutrition, which still remain challenges in many parts of the world. But we also need to act on previously excluded priorities like non-communicable diseases, mental health, injuries and disabilities, and the missing gaps in the life course, that is adolescent health and health of the elderly. We need to create strong health system platforms for integrated delivery of a wide range of health services with emphasis on equity, efficiency, effectiveness, and economic viability. We need to implement universal health coverage as the framework for achieving these goals through actions at national and global levels. We need to enable coordinated multi-sectoral action to influence the social determinants of health and link health to other elements of sustainable development to maximize the co-benefits. And clearly, NCDs and tobacco control illustrate all of these priorities in one way or the other. So when we look at the 6 essential elements that are guiding the Sustainable Development Goals according to the UN Secretary General's synthesis report presented this year, the principles are dignity to end poverty and fight inequalities. There is no greater inequity than exists today other than the huge amount of loss of life due to premature mortality due to NCDs, which is principally driven by tobacco as one of the risk factors. And tobacco does push a large number into poverty. So this is clearly linked to NCDs and tobacco control. Second is prosperity, to grow a strong, inclusive, and transformative economy. Without protected productivity and without having families suffer the consequences of a wage earner losing life or income, we cannot think in terms of sustained prosperity. So again, NCDs and tobacco control fit very well into this agenda. The third is justice, to promote safe and peaceful societies and strong institutions. So here we are talking about rights and rule of law. And therefore, tobacco control again fits in very well here for the simple reason that we are really talking about a rights-based approach to being protected from the harm of tobacco and also ensuring that the legislations that have been enacted pursuant to the FCTC are effectively implemented. Then we talk about partnerships to catalyze global solidarity for sustainable development, and this is where a wider platform is being created for tobacco control and NCD communities, not only to come together, but to engage with very many other actors and enroll them as allies in our effort. And we also have the planet to protect our ecosystems for all societies and our children, and again we see how the determinants of several of the NCDs as well as the degrading agents of our environment are so common. And then we also recognize in the last principle, people, to ensure healthy lives, knowledge, and the inclusion of women and children. Again, tobacco control features very prominently in this agenda. So whatever we talk about the SDGs is relevant to tobacco control. In terms of NCDs and tobacco in the health goal, as often repeated in this conference, the goal number 3 is to ensure healthy lives and promote well-being at all ages for all. And goal 3.4 specifically talks about reducing by 1/3 premature mortality from non-communicable diseases and to promote mental health and well-being. And one of the goals related to the mechanisms of implementation, a means of implementation, 3.A, talks about strengthening the implementation of FCTC. But the accent here is on premature mortality. And when we talk about premature mortality in NCDs, tobacco comes up very much at the top as a contributor to premature mortality. And therefore, when we look at NCDs and the price of inaction, of course, the economic costs will be spoken of later, of the $47 trillion likely to be lost between 2011 and 2030 due to NCDs and mental health. But even in terms of lives lost, between 2010 and 2025, deaths from the 4 main NCDs will rise from 28.3 million to 38.8 million. Of these 10.5 million additional deaths, 9.5 million will be in the low and middle income countries. This is a glaring example of global health inequity that we must aim to prevent, and tobacco control is the main path for that. And in terms of NCDs, the price of action as opposed to the price of inaction, 37 million lives will be saved if we act on 6 risk factors, and this is what has been postulated by Contis and others in their modeling. But the gains will be greater, as has already been spoken of, if the tobacco use prevalence is reduced by 50% instead of 30%. And of course, there will be additional gains if we also implement effective health system interventions for life-saving medical interventions. It is very clear that the health goal cannot be reached without tobacco control, because the target for premature mortality reduction cannot be achieved without effective tobacco control. Healthy lives and well-being for all cannot be ensured if the life course is not free from tobacco, from fetal life to active aging. So clearly, throughout the life course, tobacco has an influence and has a definite influence on premature mortality. If 80% of all coronary deaths below the age of 40 years are attributable to tobacco, if 60% of all coronary deaths below the age of 50 years are attributable to tobacco, clearly, no goal for premature mortality reduction can ever advance without effective tobacco control. And that is the message that will permeate the discussion on NCDs as well as SDGs. At the same time, there are intergenerational health benefits of tobacco control because there are epigenetic effects which can affect not just one generation, but 2 or 3 generations. Some of the costs are which not quantified, but certainly if we want the generations ahead to be healthy, to ensure sustainable development as we desire, then we have to have tobacco control. So again, starting off with poverty, it's very clear that you cannot achieve the goal of poverty reduction without acting firmly on tobacco, because the poor and the poorest tend to smoke the most and bear most of the economic and disease burden of tobacco use. Of the estimated 1.3 billion smokers worldwide, 84% live in developing and transitional economies. Tobacco use is rising in low and middle income countries, and there the poor bear the highest burden of not only disease but of the healthcare costs. But most importantly, tobacco pushes users and their families into poverty. So tobacco is an anathema to sustainable development, and that is the message again that will ring loudly and resonate across any global discourse on sustainable development. But to talk about some of the environmental and other costs of tobacco control, normally we talk about the healthcare costs in terms of 1 billion deaths being projected for the 21st century. But at the same time, it is a major environmental hazard because of the wood that has to be burnt for curing tobacco, and then for the huge amount of paper that is utilized, the modern cigarette manufacturing machines using about 4 miles of paper per hour. For every 300 cigarettes smoked anywhere, someone somewhere has killed a tree. And that is a cause to rally our allies in the environmental area. The huge use of pesticides, the air pollution, all of these again will ring well in terms of bringing in those environmental groups onto our platform. In terms of food insecurity, when the world wants to raise its food production to meet food insecurity, it is unconscionable that close to 4 million hectares of arable land are being wasted on a killer crop instead of producing nutrient crops. So again, we have to enter the food security debate. Water security, because tobacco is one of the most water-intensive crops. So again, that is an area that we ought to enter in. So it is not as though we are confining ourselves to the health effects, but we are relevant and we can be potentially impactful in every other discourse on sustainable development. So I would like to conclude by saying that sustainable development is inconceivable without creating a tobacco-free society. And as we move towards the goals for global health, towards the post-2015 SDGs, we are really looking at accelerating progress on MDGs, concerted action to control. That is, when we're talking about maternal and women's health, child health, we have to talk about tobacco. When we're talking about tuberculosis, we have to talk about tobacco. So we still feature there. In terms of concerted action to control NCDs, of course we are there, very much centrally. Implementing universal health coverage, NCDs are very much there. And as part of NCDs, tobacco control will also feature there. Promoting the social determinants of health, the relationship to poverty is again so clear. The relationship to education is so clear. The relationship to gender is so clear. So no discourse on SDGs can take place without tobacco control featuring prominently into that, and we have to use that broad platform. So the future lies in creating strong health systems with pro-health policies for better population health outcomes and improved health equity indices. As Toni Morrison said in the Song of Solomon, if we don't create the future, the present extends itself. We cannot afford a passive response. Our active response has to be a much more unified response on the platform of SDGs, but keeping NCDs and tobacco control very centrally on that platform. Thank you.
Terrific. Thank you so much, Srinith, for that really inspiring talk. We'll hold all the questions for the rest of the speakers to the end. So it's my pleasure now to introduce Susie Mercado, the Director of NCDs in the Western Pacific region of WHO, and she will speak about health systems and tobacco control.
Good morning. With the Framework Convention on Tobacco Control, whole of government and whole of society approaches have reaped immense public health benefits. However, in many countries, the health systems have been left behind. In fact, in some of our bigger countries, we've seen how doctors continue to fight for smoking rooms inside the hospitals for themselves. And many health professionals have not heard about the Framework Convention on Tobacco Control. So I thought I would open this presentation with a photo of a handcuff to cigarettes, to highlight how the health system still needs to be unchained from the past and from a role that seems to not have moved on with the times. We might think of the health system in relation to three roles. The first as a provider of information and services, and the obvious role that health systems play in cessation and treatment of tobacco dependence. Second, as tobacco-free settings and ensuring that all health facilities are models for effective, including the integration of tobacco control in other health services. And third, as agents for change, using evidence and knowledge to work with the community, with parliaments, with society to pass laws and to serve as activists and catalysts for new social norms. In this diagram, I've tried to capture the health system's building blocks and some new thinking in the Western Pacific region about what the attributes of a good health system might be in relation to achieving universal health coverage. So one could tackle tobacco control from the obvious components of health systems, including the health workforce, service delivery, information and research, healthcare financing, medical products and technologies, leadership and governance. But I guess the deeper questions are related to how can tobacco control be achieved in ways that show how the system can be resilient, the system has quality, the system is effective, the system is sustainable, the system promotes equity, and the system is accountable. So for example, do we have resilient systems that can withstand industry manipulation in times of disasters and calamities? And I think of the distribution of blankets with cigarettes during the tsunami in Japan. What is the quality and effectiveness of smoking cessation services? We know that smoking cessation counseling is included in the package of essential NCD interventions. But what is the quality? What are the results of counseling that goes on at the health center? How sustainable are our efforts? Have we included cessation in tuberculosis control or in maternal and child health? Does the system reach vulnerable groups who do not have access to health care, like indigenous populations, individuals with mental health conditions, migrants, persons with disabilities? What mechanisms are in place to hold heads of health facilities accountable for smoking in their institutions or continuing sale or advertising in health facilities? This graph comes from the work of Michael Thun, Richard Pito, Gillian Borham, and Alan Lopez in the Journal of Tobacco Control in 2012 at the last World Conference. And it shows the trajectory of the tobacco epidemic in relation to tobacco-related death. It seems that after the smoking rates have peaked, so that's the part of the diagram, and this is on male smokers, the part of the diagram with a higher peak, it takes about 20 to 25 years before tobacco-related deaths begin to peak. The curve for women is flatter and lower, but the trending is the same. And this means that countries that have high smoking rates today, will soon see an avalanche of tobacco-related disease that will overwhelm their health systems and deplete precious resources for healthcare. So we go to the first role of the health system related to helping current smokers quit. And we know, in fact, that there is an estimate that if adult consumption were to decrease by 50% by the year 2020, approximately 180 million tobacco-related deaths could be averted. Less than 15% of the world's population has access to appropriate cessation support, and in many countries there is nothing at all. However, something like brief advice could be very practical and could work. It's simple, it's cost-effective, it could only require 2 or 3 hours of training, and just entails the requirement of all health workers to ask all patients if they smoke, and if they smoke, to tell them that they should stop smoking because it's bad for their health. And this could increase the quit rates by about 66%. Now, does that mean these people will stop smoking because someone reminded them? Maybe it won't take that effect right away, but it will increase the quit attempts. And we know that the more times a smoker tries to quit, the more successful that person will be. Quit lines increase the quit rate by as much as 41%. And in environments where it's very difficult to find time to go to a health facility, using new forms of technology, mHealth, mobile apps, websites, and other innovative ways of helping people receive information needs to be emphasized. Many smokers can quit on their own, but there will be a percentage of smokers who will need assistance and possibly nicotine replacement therapy. And this means that governments have to put NRTs in their formularies and include this in the list of essential drugs. Can we make all our health facilities smoke-free? And I think this is a question or a problem that we all struggle with. And follow-up on the Global School Health Professions Survey, I believe, is still very relevant today. This slide shows surveys, although they're taken at different points in time, so comparison is quite difficult. But it just shows us that in Vietnam, Korea, the Philippines, and Fiji, at least 1 out of 5 medical students is a smoker. In Papua New Guinea and Mongolia, about 50% of students of nursing were smokers. 37% of pharmacy students in the Philippines, 62% in Mongolia, 50% in Fiji, and 28% in Cambodia were smoking. And this is because of the lack of policies in their schools, information, or opportunities to know more about tobacco control. But the good news is that 94% of these students have said they feel they have a role in tobacco control. Apart from smoking cessation, as a separate activity, it can be integrated in maternal and child health care programs, in tuberculosis control, in cardiovascular disease programs, and the like. The final role of the health system might be to act as a catalyst for social change. And indeed, health systems can play the role of expert witness in parliamentary hearings as they testify and give scientific evidence on why, for example, the tobacco industry targets young people, talking about how the prefrontal lobe of the brain is not developed until one reaches adulthood, and so on and so forth. So the medical community, the scientific community, the health community needs to step up its role as an advocate for policy. In the next few slides, I'd just like to share some of the work that was done in Vietnam a few years ago. And here we see a tobacco control communication center inside a primary healthcare center in Vietnam. Here we see how the health sector works with children as advocates in the community. And here we see how in Vietnam they have developed educational materials on the harms of smoking inside the home. This is the health system working with the people. The health system can also play a big role in advocating for stronger implementation of smoke-free workplaces and really advocating for a position that this is an occupational hazard. And even in small rural settings like the Philippines, like places in the Philippines where we still do not have graphic health warnings implemented, graphic health warnings can be put on health facilities, on hospital walls, and so on, so that society can see the harms of tobacco. So I'd like to end my slide by just saying a few things about the need to refuse tobacco industry funding for painting hospitals or upgrading cancer wards, which we have seen in some countries. The need to remind medical researchers to not accept money from the tobacco industry and to turn down donations from the tobacco industry during emergencies and disasters. These all point to the fact that Article 5.3 of the Framework Convention on Tobacco Control has not been internalized by the health system. So if we are to accelerate WHO FCTC implementation, we need to unchain the health system from old, outdated beliefs and practices. And with this liberation, our health systems can be powerful platforms for cessation, models for tobacco-free settings, and true agents of social change for public health. Thank you.
Much, Dr. Mercado. I would now like to invite Katie Dane. Katie is Executive Director of NCD Alliance, a global network of 2,000 organizations in 170 countries. And Katie would be speaking on building a civil society movement on NCDs and tobacco control.
Thank you, Monica, and good morning, everybody. So today I'll talk to you a little bit about building a civil society movement for NCDs and tobacco control, but I'll start off by saying that what I'll really be focusing on is how we can strengthen the civil society movement, because obviously over the last decade there's been a lot of fantastic progress in terms of building the civil society movement for these issues. My presentation will focus on three main areas. Firstly, the role of civil society, which has been talked about a lot throughout this conference this week. Secondly, in terms of the changing landscape, both in terms of actually the civil society context, but also in terms of the political context for NCDs and tobacco control. And then thirdly, what I'll be really focusing on is the enabling factors for a strong civil society movement, drawing upon the lessons learned from the NCD Alliance and other civil society movements in health. So firstly, in terms of what is the role of civil society, the way that we really see it in the NCD Alliance is that there's three primary roles of civil society in the NCD response. Firstly and foremost, global advocacy or national advocacy, really trying to generate political priority for these issues within governments or within the United Nations. And I think the most difficult part of advocacy for issues like NCDs and tobacco control is actually trying to sustain the political momentum around these issues. Secondly, in terms of service delivery, many civil society organisations around the world where governments are relatively weak are providing essential services, whether it be in terms of prevention or treatment for NCDs and tobacco control. Thirdly, and an increasingly important role for us in civil society is around the watchdog, the accountability role, ensuring that once commitments have been made by governments, that we're actually keeping them to their promise and keeping them to their word, and that those commitments are then translated into action and implementation on the ground. So how has the actual global landscape of civil society changed? I think it's changed enormously over the last decade or so. Firstly, there's been an enormous growth in the actual number and diversity of civil society organisations in the field of tobacco control and NCDs. Secondly, we have greater influence in terms of shaping local and global agendas. And this is partly because of governments' increasing recognition of the importance of civil society in terms of policy development and in terms of implementation. Thirdly, in terms of the growing mobilisation of civil society organisations through important alliances such as the Framework Convention Alliance for Tobacco Control and also the NCD Alliance over the last 6 years. And then finally, in terms of an increasing resources channeled through civil society, although I should say that there's obviously a huge capacity issue within many low and middle income countries still for civil society to play a meaningful role in the NCD response. Secondly, in terms of the political context, this has changed hugely over the last decade. Obviously, with the FCTC adoption and then implementation over the last decade, but within the NCD political response, things have changed significantly, particularly over the last 5 years. The way we see it is very much a four-phased approach. 2011, with the UN High-Level Summit on NCDs, was when we achieved global commitment for this issue, both as a health issue and as an international development issue. Secondly, in 2013, governments agreed to a global NCD action plan and the first set of global targets, 25 by 25, plus the tobacco control target and 7 others. This was a point at which we finally achieved global accountability for NCDs. Thirdly, in terms of global coordination, just last year, the United Nations convened a UN interagency task force on NCDs, which will harness the entire UN system's resources and expertise for tobacco control and non-communicable diseases. And as Dr. Reddy has presented already, the next real challenge and opportunity is really ensuring that tobacco control and NCDs are included in the successor goals to the Millennium Development Goals. So this is all to say that the political context that we're working in as civil society has changed dramatically over the last decade or so. And so in a way, we're really reaching into a new dawn, a new era for tobacco control and NCD advocacy. And this means that we as civil society need to shift and align ourselves around these new opportunities and challenges. And so in terms of when thinking about what are the key enablers to really strengthen the civil society movement for NCDs, I'm going to be touching upon 4 key enablers that we see in the NCD Alliance. First and foremost, actor power. When I say actor power within civil society, I mean leadership, I mean champions, and I mean the guiding institutions within civil society that can really accelerate the response for civil society at national and global levels. In terms of actor power, alliances are absolutely essential. We've seen the effect and the impact of the Framework Convention Alliance over the last decade, and more recently, the NCD Alliance as well. And importantly, at the national level, what we're now seeing is an emergence of national and regional NCD alliances. We now know of over 30 national and regional alliances which are playing a really important role in NCD advocacy with their governments and have a very strong relationship with their ministries of health and other governments, other departments. So ensuring that we have effective alliances that can really bring people power and legitimacy to the civil society response is absolutely key. But in terms of actor power, alliances are important, but they're only effective if they've got very strong grassroots. And this is a real priority for the NCD Alliance going forward. We've established a strong global alliance of 7 federations, 2,000 organisations in 170 countries. But we really need to focus on strengthening the capacity of our grassroots organisations, particularly in low and middle income countries, so that they can play that meaningful role in the NCD response. And also in terms of active power, we really need to think about widening the circle. We need to be thinking about who are the unusual suspects that we need to be talking to, because we can't continue to be just talking to ourselves. We need to be bringing in the gender and women's groups in countries. We also need to be talking to agriculture, we need to be talking to finance, we need to be talking to all these different civil society organisations across this spectrum of sustainable development, which is going to be the main platform going forward for international development. The second enabler that I wanted to mention was really how we frame the issues. And this is important because this is how a community really understands the problems and the solutions. And it ensures that we as a civil society movement are credible, and it really averts fractious issues going forward. And obviously we're not always going to be able to agree on certain things, but we need to have a level of understanding and consensus around priority issues. And this is not easy within non-communicable diseases or tobacco control. These are inherently complex issues that we're dealing with. 4 diseases, 4 risk factors, plus mental and neurological health. It's not an easy agenda to be working on. But it's absolutely essential in terms of the community that we have that internal policy cohesion, and that we're essentially all singing from the same song sheets in terms of our advocacy with governments. We also need to be thinking about what are the messages externally that we're using with these different audiences and different target groups. And one way of thinking about this is in terms of the head, the heart, and the pocket. We need the hard figures, the numbers, to be talking about the scale of the epidemic. But we also know that the numbers aren't enough. We need human stories to be really making the case. And we also need to be thinking about what are the economic arguments, which the next presenter will be talking about, that will really catalyse action and foster implementation. We also need to connect the dots, and this is important particularly in terms of the next 15 years of international development. This is going to be a sustainable development agenda with 3 pillars: social, economic and environmental. As Dr. Reddy said earlier, we really need to be making the case for tobacco control and NCDs to be linking with these other issues and these other priorities. Because although the Ministry of Health and the health agenda will be important, there's going to be a growing complex number of issues that we're dealing with. And so we really need to be making the case for why tobacco control interlinks with all of these issues. And also we need to be talking about tobacco control and NCDs as an integrated agenda, both together but also across the whole health agenda as well. Integration is absolutely essential, and it's been very much a mantra of the NCD Alliance over the last 6 years, that we're not calling for a new global fund for NCDs, we're not calling for new siloed programs at the national level. What we want to do is really integrate into what's already there. Thirdly, we need to really maximise the political opportunities that lie ahead. And this is in terms of the real policy windows that we can see from the civil society perspective. And it's absolutely essential from a civil society perspective to know the process. It's not a particularly glamorous job to really be tracking and understanding what's happening at the national level in terms of policy development or at the global level, but it's absolutely key if we're actually going to make an impact and see change. And I think, from our perspective, the post-2015 agenda has been one such process, which has been extremely complex. It's been a bit of a marathon, and it's been a 3-year process. But one of the NCD Alliance's core jobs is to really understand the process, to identify how civil society can get involved. And at the global level, we have a few opportunities that lie ahead. Obviously, post-2015 and the Sustainable Development Goals are one such opportunity. But we also have the United Nations agenda coming up, including a follow-up UN high-level review on non-communicable diseases, which is scheduled for 2018. And we obviously also have the FCTC and the COP as critical opportunities at the global level to really push this agenda forward. At the national level, in a way, what we've done at the moment is really shifted responsibility. We've handed the baton over to governments to really take this agenda forward. But obviously, as civil society, we can't let go. And we need to be really leveraging the opportunities that come in front of us at the national level, whether it be in terms of governments developing national NCD plans, national commissions and national targets to ensure that we're really on the front foot and maximising these opportunities at the national level. But also, as I said, we need to keep government's feet to the fire. And increasingly, I think the civil society movement for NCDs needs to play much more of an active role in accountability. And accountability is twofold. It's thinking about the official monitoring processes that governments go through, whether it be at the World Health Assembly or at the COP or at the UN. But it's also in terms of our role as civil society to play that independent accountability role. Because we can conduct activities such as shadow reporting or benchmarking of progress to really push the agenda forward. And the fourth enabler, and the final one I just wanted to mention, was around knowledge exchange. I think the civil society movement can grow and strengthen so much more if we actually learn from one another. And I'm not just talking about how we can learn from tobacco control for NCDs, I'm talking about how we can learn from other civil society and social movements within health and international development. And a critical part of knowledge exchange within civil society is being able to monitor what we're doing, monitoring campaigns that we're running, monitoring the actual impact of services that we're delivering, monitoring initiatives around accountability, because that's when we'll really understand what's working and what's not working and be able to translate and scale those messages across countries and across regions. Thank you very much.
Please thank her, and I'll change the slide.
Thank you very much, Katie Dane. Our next speaker for today is Dr. Michael Engelgau. Dr. Michael Engelgau is Deputy Director, Center for Translation Research and Implementation Sciences at the National Institutes of Health. And Dr. Engelgau would be talking on economic costs of inaction.
Okay, thank you very much, Professor Aurora and Professor McKay. It's a real pleasure to be here and join the conference. I have the tall task of trying to, in a few short minutes, convey how important economics are to this 20th century tobacco epidemic. And what I'll try to do is just walk you through some fairly, hopefully, straightforward examples and show the relevance. And even though you're not going to, I don't want you to feel like an economist after you leave this session, have a good grasp on what some of the key issues are and how they can help us in our efforts. And I wanted to just start out with a little bit of history. Economics has been called the dismal science, and this is from about the mid-19th century when that was first coined. It's about making tough decisions, taking scarce resources and allocating them. There will be winners, there will be losers. There will be this concept of opportunity costs where if you spend that money one place, you can't spend it somewhere else. And dealing with that and just how to best get the most out of our efforts and resources. So what I wanted to do is kind of look at some of the dimensions of the tobacco economics and touch on very quickly the cost of tobacco use and some of the high points there. Look at a couple economic interventions for demand reduction and supply reduction, and then a quick look at what some of the major challenges ahead are for us. So if we look at the cost of tobacco, and this example I have here is from China, these numbers are driven by basically three elements. The first is the smoking attributable fraction of the disease burden that it caused. And it's fairly substantial. And the second is the size of the country and then the prevalence of smoking. And so here with China, we have a large country. We have a fairly high smoking prevalence. And you can see here roughly approaching 1% of the GDP is spent on direct costs, which are the medical care costs attributed to tobacco, and indirect costs, which are the premature disability, premature mortality, and the foregone wages that happen with that situation. And these numbers are very large, in the multiple billion-dollar range, and appear to be substantially increasing over this fairly short time period here in China. And if we look across the globe at cost of illness studies, they're always just astronomical numbers. The 50th anniversary Surgeon General report has a chapter on the cost of tobacco in the United States. It's done very well, includes both direct and indirect, and also the cost of exposure to secondhand smoke, a very important component that hasn't been in earlier studies quite so much. And I mentioned the smoking attributable fraction of the disease burden, and there's been some new studies looking at that more carefully. One just came out fairly recently showing that there is a relationship between tobacco and even more diseases that we thought previously. So when those are worked in, these numbers will become even more. There's evidence, as we see in China, that the cost is growing. And then back to this concept of these opportunity costs. These are billions of dollars that we're spending on tobacco-related, which all are preventable. A tremendous amount of budgetary space if we could get that and use it in some other way. So the first example we looked at was within the health sector, looking at care, death, and disability, and that's kind of our comfort zone. But with economics, you have to get outside the health sector, and I have listed here a number of places that are very important for the economics of tobacco. And what's very reassuring is that if you look at the program and the sessions and the presentations here at this conference, many of these have been taken head on and getting a lot of attention. And the other nice thing about the FCTC is that it does include these elements with lots of direction, help, and support guidelines on how to take on some of these things which are out of our comfort zone, not connected with the health sector in the traditional way. So what I wanted to fairly quickly do here was just look at an economic example for demand reduction, hopefully one that you're all pretty familiar with, and this is looking at taxes to reduce consumption. And the opening ceremony, I think it was Director Alwan made the point. He said that taxes was the best tool we have and you should use it as much as you can. And he's actually right with that statement. And here's an example of a study done this year in Greece looking at a tax increase in the price of cigarettes, and they basically found that a 10% increase in cost will translate into about a 4% reduction in consumption. And this is a fairly, the range that you would see of the other studies that have been done across the globe. In low-income countries, poor countries, you may see a larger reduction in consumption. In higher-income countries, it may be less. And then if you look at the taxes that are involved, there's a number of different ways the taxes all come together. It can be rather confusing, but the important piece is that there's a substantial increase in the retail price. If that doesn't occur, you probably will not have impact with an intervention like that. The tricky part is that in some cases, industry can lower their profit margins so that even with an increase in taxes, the cost of the cigarettes and tobacco products may stay the same. But one of the challenges here, and this is a very important economic concept, is that we will get people to stop smoking, but not everybody will. And some of those people will be poor and vulnerable populations. And it may result in what we'd call a regressive taxation, where they would be spending money on tobacco and foregoing social investments such as schooling, education, even food in some cases. I was just in a session where the household diet was being compromised to a certain degree because of the expense in these low-income households for buying tobacco. So a very, very important intervention for us to understand the ins and outs. And then I just very quickly wanted to look at supply reduction, and I think most think of illicit trade and bans. I just wanted to quickly look at crop replacement as something as we start to face the end game with the tobacco efforts. And considerations have to be comprehensive when we look at this type of approach. Along with crop replacement, you need to figure out the market modifications, labor adaptations, and then the revenue streams that will be changed. And there is some experiences around the globe, a handful of them. I just wanted to briefly look at a pilot that was done in China, in the Yunnan province. Yunnan is where most of the tobacco from China is grown. It included 3 sites, over 400 farming families with fairly low educational levels. They developed a co-op and a business model with local management. They had an academic partner that helped with some of the training and technical support. It was actually a U.S. institution, UCLA was the partner there. And they each selected a crop that grew best in their situation and their site. And you can see there's a handful of different vegetables and products that they grew, but uniformly their income was increased from 21% to 110% over what they were getting from tobacco. So a rather favorable outcome here. And this is the business model that they developed. And you can see on the left, the academic partner, UCLA, on the bottom, the Bureau of Agriculture, the markets on the right, and the distributors on the top. What you don't see is the Public Health Department or the Ministry of Health. Our role is critical to facilitate these types of activities and interventions in a advocacy role and an oversight role, and to bring together these critical partners when we get outside the health sector with these types of efforts. And this focused primarily on crop replacement and market modification, but there's other challenges when you take on these types of supply reduction efforts. There may be some labor adaptations downstream. The truck drivers could be, instead of hauling tobacco, could be taking produce, but there may be some other labor that needs to be understood. And then the revenue streams also need to be familiarized and understand the impact it may have at the local, provincial, and national level. And I just put on this, nearly 8% of the tax of revenues to China in 2005 were from tobacco taxation. So it's not an insignificant number, and these need to be addressed and understood if we're going to make these efforts sustainable moving into the future. And so what is our challenge ahead? And hopefully most of you made it to the Bloomberg Awards on Wednesday night. And there was a section during the award ceremony where he was interviewed. And I have it on the slide here. The comment that was made to him was congratulations on investing $600 million in tobacco control during the Bloomberg initiative. And he said, thank you very much. The only problem is that during the same period of time, the tobacco industry invested $8 billion. So the task in front of us is somewhat onerous. And I just wanted to finish here with an article that was published in the Lancet last week. And this is a very, very hard-hitting article. The Lancet actually is starting a series on tobacco. Some of the authors of the papers are here at this conference. This was actually written by the editorial staff. And the question it raises is, what will it take to create a tobacco-free world? When I read this, I'd never read an article quite like this. The first paragraph basically gives a portfolio analysis of the British American Tobacco Company, and it's a glowing report. They have, roughly 3 to 4% growth. They have 4 to 5% increase in profits, and everything is going well. So Lancet is pretty hard-hitting here, comes around and sums this up in their final paragraph with this very hard-hitting statement that the current tobacco global anti-tobacco strategies are failing, and we endorse the series call on a UN high-level summit on tobacco use, because tobacco is not just a health threat, it's also a threat to sustainable human development. And I think that's something we really need to keep in mind. It's much bigger than just the health effects. It goes way beyond the direct effects that we see in people who smoke, but can actually work against human development. I do think I'm a bit more optimistic than Lancet. It's very gratifying to see some energy and creativity and momentum at this conference. Very important that we package that up and take it back with us as we go home and get the efforts on the ground so that we can really have some impact as we move forward. Thank you.
Thank you very much indeed, Michael. We now open this to a panel discussion, and anybody is more than welcome to come to one of the microphones and ask a question from the floor. In the meantime, I'd just like to introduce a panel member, Kerry Adams, who is the Chief Executive Officer of the UICC and is Chairman of the NCDA, and he joins us to answer questions. We have people lining up. Very nice. Could you identify yourself and ask your first question?
Hello, I'm Paula Snowden from New Zealand. We've had a progressive tax increases which are getting results and are hitting our low-income smokers very hard. In the meantime, we know that the tobacco industry makes more and more profit. So can I ask the last speaker, are there ways to tax to get cessation that don't just hurt the consumer but hurt the producer?
Michael.
It's a great question, and one that really needs to be carefully studied. Taxation, the concept is pretty simple, but it can be very complex, the way governments implement them, the way the industry can manipulate the profit margin they have to kind of neutralize the effect of the tax. So that's an area which really needs to be looked at. The point I was trying to make is that there are vulnerable populations who really do suffer from higher prices for tobacco. They're already buying it, they're not going to quit, and to understand how that works so that we can come up with strategies to minimize that human development that we're affecting just because of the tobacco.
Thank you. And we have had another question that's directed at Carrie, and that is that I'd like your comments on how we deal with some of the other industries involved with the broader spectrum of NCDs. We've always considered that tobacco was rather unique in what a terrible industry it was, but we're seeing some similar behavior from the alcohol and sugar industry, and they, of course, are an integral part of NCDs. I wondered if you'd like to comment as to whether we should firewall these industries, whether we should work with them.
Thank you, Judith. Well, first of all, let me make it clear that I don't think there's any way that we could ever undertake a discussion with the tobacco industry, whether that be a government, NGOs or others. So, I mean, they're clearly out of the room and cannot join into a conversation when it comes to NCDs. But I think we have to be wise and cautious in perhaps not looking at some of our other industries and painting them with the same brush. Without doubt, there is a need of dialogue across many types of organisations in order to make the progress that we want to make against the NCD targets, and that was articulated in the political declaration in 2011 when there was a call on all parties, academia, private sector, civil society and governments to work together to resolve the NCD problem in the long term. A couple of reasons why I think that we should engage, or at least talk to different parts of the private sector, perhaps be more cautious with the tobacco and the sugar industries than others, is actually what Srinath said earlier about the SDG, those guiding principles or elements, and one of them being prosperity. And that we know that the private sector over the last 2 centuries has been a driver of economic growth around the world, and actually highlighted by the negative impact, which we just saw about the tobacco industry having a 0.7% GDP impact on China, a negative impact. So the private sector has both a positive and a negative impact, and we should ensure that we recognize that future prosperity is probably through an aligned private sector community which is working in the right way, not undermining health goals and not undermining any gains that we can achieve. So I think that's the second thing to bear in mind, that a lot of the sustainability goals will rely on all parties to contribute in a positive way. The other thing about the private sector is that about 60% of all people employed are employed by companies. And what we're seeing through NCDA is a lot of companies recognizing that wellness at work programs are not only good for society, because it's such a large number of people who will be affected, but secondly, it actually is good for their business in all different ways. So I think that the way that we address the private sector outside of the tobacco industry, we should be wise and cautious, but we should not colour everything the same as the tobacco industry. It's a complicated issue, And that's why we've seen, for example, the World Health Organization grapple for some 3 years to understand what is the relationship the WHO should have with non-state actors. I'm hoping that will be concluded in May this year. And that will give us a steer and direction of some principles through which I think a lot of us in the civil society movement, as well as member states, can adopt and apply with the knowledge that those who are the wisest in terms of addressing and working with the private sector have had an opportunity to express that, and it's been appropriately summarized in a document from the World Health Organization signed off by member states.
Thank you very much, Kerry. We have a lot of questions, so if the questions and the answers indeed could be really brief from now on. Could we have one more question from this side?
I am Farida Akhtar from Bangladesh. I have been listening to the speakers, but my question is particularly to Dr. Reddy and to Michael. And we are talking about tobacco use in relation to NCDs, and tobacco use is smoking and smokeless. But I think we should talk about tobacco exposure and NCDs because it should include the tobacco farming, which also has as much nicotine exposure to the workers and the farmers and are causing NCDs. So that is one thing that I think has been ignored in many of the discussions. And I didn't hear about GTS talked about very much. And also about mental health and maternal health. These are two very important issues that are affecting, women in particular in those areas. So that has to be recognized. And to Michael, I just want you to list another country, Bangladesh, where crop replacement is in place in tobacco fields where farmers are getting out of tobacco. And, it's IDRC-sponsored research that we have shown. And finally, one thing, the Bloomberg Initiative somehow does not support tobacco, any work on the tobacco cultivation part. So I will request Bloomberg Initiative to support stopping tobacco cultivation initiatives. So,
thank you. Michael, perhaps, or Srinath, perhaps.
I completely agree with every single thing that you said. Yes, we should talk about tobacco exposure, active, passive, and occupational, and everything else you said about women's health, mental health, and looking at the supply side action and assisting transition of farmers to alternate livelihoods. All of that I fully support.
Thank you. Could we have the next question, please? I'm sorry, we really have to move on. I think we're all in agreement on that question in particular.
Hello everyone, I am from Mongolia. My name is Bayratar. I would like to ask Ms. Susan Mercado from WHO Wipro office, how are you showing youth participation on tobacco control beyond 2025? What's your imagine on it? Thank you.
Susie. It was for Susie. I'm sorry, we just didn't hear the question very clearly. It was to do with 2025.
Yep. I would like to ask Wipro office.
Yes, a Wipro.
How are you showing youth participation on tobacco control beyond 2025?
I think you're being asked for your vision beyond 2025 in terms of tobacco.
Youth participation.
Yeah, youth participation.
Youth participation.
All right, okay. In many of our activities with the member states, the youth have played a very important role in tobacco control. I think at the last World Conference, we saw a big initiative by Singapore on youth and tobacco. And in many countries, we now see sort of youth ambassadors, young people like singers or actors or television personalities who are getting involved. I think the use of social media and the use of more web-based activity for advocating for tobacco control are some indications of how countries are engaging the youth in tobacco control.
Thank you. Dilip.
Judith, I'd like to compliment Monica and you for putting together an excellent session. It really was very, very good.
Thank you.
That said, John Seffron and I did an editorial 14 years ago on many of these issues, And the editorial was entitled, it was specific to cancer, on what don't we know and when didn't we know it. Many of these issues are not new. And I love Judith's comment. I mean, the problem with Judith's comment is she said it with her customary degree of civility. She said, these chaps are not delivering the money that they promised. And that is the problem. To me, the two big problems are, one, people are not putting the money that they promised. Two, civil society is not holding their toes to the fire. I think civil society should remake themselves into a somewhat incivil society. Civility, in California, two of the things we had, one was money and the other was outrageousness. And the third thing we have is the next speaker on the other end, people like Stan Glantz, who were very, very effective because they were gloriously incivil. They made sure that when I was in government that I did my job. Otherwise, they said, Brutus is an honorable man, we love him, but he's not doing X, Y, Z the way he should do it. I think that's lacking in the international community, Judith.
I think perhaps, Kerry, would you like to comment with that we've become too civil in terms of dealing with the tobacco industry, and all our activism of the early years is becoming a little faded in terms of working more with governments rather than challenging them?
I'm more than happy to answer that. I think that the way you should measure the effectiveness of civil society is what actually is achieved over time. And as Katie presented in her chart, if you go back only 6 or 7 years ago, NCDs were certainly not on the global health agenda. The MDGs did not include NCDs or tobacco. There'd only been one health summit on any health issue, which is HIV/AIDS, in 2001. And as that chart showed, we've made tremendous progress. And that there has been a number of discussions at the NCD Alliance Steering Group, at which point do we show outrage, and at which point do we work with and we collaborate, we inform, and we ensure that the baseline of a framework is put in place to allow others around the world in country to adopt the style they require in order to galvanize government activity in the areas that we have so well articulated through the Global Action Plan, particularly Appendix 3 and the various targets. So I think the balance has probably been right over the last 4 years, but I would not discount uncivil behavior in the future if it's absolutely appropriate in a country context.
Thank you. We've got 3 more questions and we've got 3 minutes. So my biggest challenge as a chair, and Stan's biggest challenge as a questioner, is to ask a single sentence question.
Okay, well, the first thing, and I know this is a little co-opting the meeting, but I got bumped to a flight from Dubai because of the strike, the Lufthansa. And so if anybody's going to Dubai after this session, could you tell me so maybe we could share a cab?
That's your one sentence, Stan.
Okay, well, I'll stop there. But I just want to have to comment on what Dilip said because I do think there is a role for beating up government, and there's even a role sometimes for people in government calling you at home late at night suggesting that there's a need that they be beaten up. And you know, I think that is an important role for the bureaucracy. The substantive comment that I'd like to raise, I think this is a very encouraging panel, and I think that one place we've made a big mistake for years is letting the tobacco industry take control of the economic argument, because as several of the speakers pointed out, I think if you do a proper analysis, especially when you look at things like heart disease, asthma, complications of pregnancy, the economic benefits in terms of reduced tobacco consumption appear very, very fast. And I think not that we should not worry about cancer, but the focus on cancer, which takes much longer, is not played so well. So my one run-on sentence is just to encourage people to really be focusing more on these short-term benefits of cessation because they're very large and they occur even within the lifespan and time, attention span, I mean, of politicians. So my question is, do you agree with that?
I think that sentence is on record for having the greatest number of commas I've ever heard in a single sentence. Dan. I think we're all agreed that the tobacco industry have hijacked the economic argument. We have to reclaim it. We have to embrace all the economic arguments because they are the biggest obstruction, the misconceptions of economics to governments taking action. Can we just have very briefly the next question?
Okay, I'm Paula Jones from Brazil. Yes, I'm trying to make a one-sentence question. My question goes about like this dialogue with private sector. I would like whether, are there any global economic studies showing what's the participation of small business in economy and what's the participation of like these transnational companies in economy? Because when it comes to NCD, it's not about not talking with the private sector, it's like which private sector are we talking with? Just to finalize with an example, in Brazil, 70% of the food that we eat are produced by small farmers. The rest, where the major investments go to, are commodities. So just a question, which private sector is that?
I think Michael might answer that very briefly, but actually it's a topic for the next conference.
Yeah, I don't know, and I apologize, I don't know of any, it's a great question.
Yes.
When you think about, you know, what your target should be if you're going to action, you know, some type of effort. But that's where we do have information gaps here. It'd be very important to get that type of information.
And the last question?
Thank you very much, Professor Mackay. My name is Craig McLean and I'm a medical student at the University of Dundee. We heard talk that countries who are already advanced in tobacco control should look beyond the goals in reducing tobacco prevalence. And some countries, such as New Zealand, Australia, Scotland, have set a target of 5%. How do you think, what methods do you think we should use to achieve that and create that accelerated decline in the use of tobacco? Thank you.
Any offers for people? How are we really going to deal and to manage an announced target in terms of, I mean, governments announcing roadmaps to achieve that, which is something they clearly have to do. Srinath.
I think the fact that such targets have been set, and they seemed ambitious when set, but definitely can be accomplished because the political will has been created. There has been a consensus among a number of stakeholder groups in the society which desires that this is a target that should be accomplished. I think the trajectory of tobacco consumption decline in countries such as New Zealand and Scotland can be accelerated further if there is effective implementation of all the well-known strategies. What has been previously missing in the whole element was strong political will. So with a combination of strong political will and professional skill among the implementers, I think it should be possible.
Susie.
Just a brief comment on that. I think what we're seeing in our region in the developed countries is that increasingly, as your prevalence rates go down, the inequities become more manifest. And so the focus of tobacco control has to be on marginalized groups, indigenous people, people who don't have access to healthcare, and so on and so forth. So while you sort of reach a good population target for cessation, you also still have those pockets of communities that need intense public health interventions.
We've just had one comment in on gender, and I'll just explain that and then hand over to Monica to close the session for her concluding remarks. And the one on gender is the need for us to perpetually keep it on the agenda, not only in terms of the FCTC, but also in terms of conferences like this. And there's certainly the encouragement to South Africa to really maintain the standard that was set in Beijing at the World Conference in 1997, where women were half of the panels, as we see today, the chairs, that their participation was really full at every level, and how important that was to carry the goals of sustainable development forward in terms of tobacco control. I'm just being asked to read that out.
Thank you very much, Judith. In my closing remarks, I would like to thank the eminent panelists who are here with us today. This has been a very enriching discussion and debate. Just to summarize the session, we did highlight that for tobacco and NCDs vision of 2025 and beyond, we are gearing up with data, research, advocacy, systems, partnerships, and civil society action being integrated. And as we move towards the 2025 global NCD tobacco target, it is good to see that 125 countries are seeing a downward trend, but the fact that only 37 countries are on that slope and that will meet the target, we really need to think about how we get more and more countries to adopt the higher relative reduction targets. And gain will be greater if tobacco control targets are prioritized and increased. Also to highlight that tobacco control is integral to all the 6 essential elements of the Sustainable Development Goals, as we heard from our panelists. And very importantly highlighted the role of health system and health professionals in intensifying tobacco control, their engagement not only in service provision but also as advocates. Role of civil society has always been important to the tobacco control movement, and this has to continue as we move into integrating tobacco control into the agenda of non-communicable diseases and to the sustainable development agenda. So I would like to close the session by saying that we have discussed the themes of integration, synergizing global targets, goals, and efforts, and we hope the next World Conference on Tobacco or Health, we are able to have the same plenary with progress shown and discussed, and hopefully more countries would be on the downward trend of showing reduction in tobacco prevalence. Thank you very much.
Thank you, Speaker. And just finally, to thank all of our speakers for participating in this panel. Thank you very much indeed. Thank you. Yes.